Welcome to the podcast of the American Journal of Psychiatry Residence Journal. Today, our associate editor, Dr. Helena Winston, sits down with Dr. Joel Yager.
Hello, so my name is Helena Winston. I'm a PGY3 at the University of Colorado in the Psychiatry department. And I'm here with Dr. Joel Yager, Professor of Psychiatry at the University of Colorado. And I'm going to ask him a couple questions and get his perspectives on his life experience. So my first question is, would you mind telling me a bit about your education and the course of your career within psychiatry?
Long story.
I know.
But I'll make it brief. I grew up in New York City, which was phenomenal. Went to the City College of New York, which was spectacular, and to the Albert Einstein College of Medicine, which was a terrific medical school, which was about a mile and a half from where I grew up. And it had the benefit of allowing me to continue to play with my band, because I wanted to stay in New York City. So we had to do weddings and bar mitzvahs, and I could do that because all of my friends were still there. It was a top 10 medical school. And I actually had the experience of taking care of friends and relatives as a medical student and resident. So it was a community school for me. The school had a spectacular department of psychiatry and a very good department of internal medicine. So after medical school, I did a medicine internship, really thought about going into internal medicine, but still found that I loved psychiatry and stayed there for my residency, in part because I met my wife, who was a year behind me in medical school, and she did her pediatrics training while I did psychiatry. I couldn't have asked for a better experience either in medical school or as a resident. Following residency, I went into the Army because in 1969 there was something called the Vietnam War going on, and there was a program called the Berry Program, which assured, if you signed up for it, that you could finish your residency and not be drafted as a general medical officer and sent to Vietnam as frontline cannon fodder. So I did that, and remarkably was assigned as a psychiatrist to Fort Ord, California, which was right just north of Carmel. So you couldn't have asked for a better place on the planet to do your military service. Fort Ord was a huge Army base with about 100,000 active duty personnel and a 900-bed hospital that had between 40 and 60 psychiatric beds, half of which were devoted to people just admitted to the Army who went crazy because they were drafted, and the other to people who were just out of the jungle in Vietnam, who were being sent back after having had some kind of an emotional nervous breakdown during combat or at some other point. So this was a very active military hospital. For the first year there, I ran an inpatient service, which was very educational for me, and I hope useful for the soldiers. I mean, these were tragic lives. And in the second year, I sort of wangled a position for myself doing outpatient work and research. So that was also very professional and useful, and I set up some teaching programs. Once we were in California, I decided we really liked it. And our son was born, and we then decided we would stay in California, and I looked at jobs at Stanford, UC San Diego, which was a brand new medical school in those days. And one of my faculty supervisors from Einstein had just come out to be vice chair at UC San Diego, a fellow named Sam Barandas, who was a brilliant, terrific guy, who then went on to become chair at UC San Francisco. But Sam insisted that I come and see the new department, and they absolutely seduced us to come to San Diego, which was a beautiful place, and we were there for 2 years, and my intention was to do a research fellowship in psychopharmacology at that point. After being there for a year, a month, it was a very chaotic department. Somebody was fired, and I was made chief of outpatient services. So that was the end of my psychopharm fellowship. So I ran a a clinic, an emergency room, and a day program. And I did that for about a year until they opened the new VA hospital in San Diego, and I was the first psychiatrist on staff and ran the CL service for a year. And all of that worked well until I was recruited by UCLA to come up to UCLA. I was at that point 33 years old, so I had been through my residency, 2 years of the Army and 2 years of UC San Diego. In New York City, we grew up very fast. And at 33, I went to UCLA and became director of the residency program. Was recruited by the phenomenal chairman, a guy named Louis Jolyon West, a huge bear of a guy, and was terrific. And the story was that they seduced me with bagels because Los Angeles had much better bagels than San Diego. We also had relatives in LA, and some of my dearest friends had come to to be at UCLA, and Eileen and I really wanted to join them. And it was a big city, and we were big city people. So we stayed at UCLA from 1973 through 1995, and I was vice chair for education and ran the residency program and kind of coordinated UCLA's 5 residencies in psychiatry and had some hand in all of the fellowships and medical student programs and so forth. It was a fabulous experience. Big earthquake in Los Angeles in 1994, and Eileen, who's my wife, who was co-director of the residency program in pediatrics at that time, said, "Well, I'm leaving, do you want to come?" So we made a decision to leave Los Angeles at that point. And I had been there long enough to be an emeritus professor, so I'm an emeritus professor there. And I said, "Well, where do you want to go?" And she said, "No earthquakes, no hurricanes, no ice storms." And that left Arizona and New Mexico, basically. And Arizona was too hot. And at that point, New Mexico was just putting together its department again with a very nice group of people. And Eileen and I were recruited to the University of New Mexico, which we knew would be a way station until our kids figured out where they wanted to settle. So we were at UNM for 13 years, Eileen in pediatrics and I was in psychiatry, and long enough to be an emeritus professor at the University of New Mexico. And at that point, our daughter Allison decided that she and her husband, he's a nephrologist, and she did her pediatric training here, that they were going to stay in Denver, and they started to have these things that we call grandkids. So there was no question about who was going to move where. We came up here, and we've been now in Denver for the past 9.5 years, and absolutely love it. When I came to the department here, Bob Friedman, who was the chairman, asked, "Joel, what would you like to do?" And at that time, I said, anything but administration. Having done a ton of administration at UCLA and also at the University of New Mexico, where I was vice chair for education and academic affairs, and it was great. Had a lot of terrific experiences, did a lot of research, scholarship, writing, national things. But by this time I said, I'll give the administration to somebody else. So I've been devoting myself to teaching for the most part, and a lot of scholarly work, and also some national work.
And can you tell me a little bit about those projects, some of the highlights that you're working on here and nationally?
Sure. I've had a number of different streams of scholarship in my life. Eating disorders has been a large stream. At UCLA, I started the Adult Eating Disorders program because in the early 70s, the residents were coming to me and saying, "We have all of these women coming in and they're either starving or binging and purging. What do we do?" And I said, "Well, we'll put them all in a group and they'll tell us about what's going on." And so we learned. We started a group, we started research, we did a whole bunch of projects, and I did some work, again, with anorexia nervosa and bulimia, a lot of writing, and coordinated the practice guidelines for the American Psychiatric Association, editing and chairing the group on practice guidelines through 3 editions of that. I also got into practice guidelines and health services research through the APA, and had research in that area with primary care mental health services and minority mental health services that I continued at UNM. So the eating disorders business was one piece of this. I became president of the Academy of Eating Disorders, edited a newsletter for 25 years. I've been doing a lot of, did a few books and all of the things that you generally do when you're putting your mark on a subspecialty in psychiatry. I've done a lot in consultation liaison. I was on the consultation liaison faculty at UCLA. Did a lot of writing on that. Primary care integration with the general internal medicine faculty. Family psychiatry. I just have always liked to do a lot of things and kind of extend my interest into different areas. In terms of psychotherapy, I got interested in interpersonal therapy, started to teach it, got films, got some of the original material that had been used to develop that area, and made interpersonal psychotherapy another hat that I wore from time to time. At UNM, New Mexico is very interesting in having a very diverse population. So I had a Native American administrative assistant and some Native American students, and several of our Hispanic and Native American students came to me and one of my colleagues, a guy named Howard Waitskin, who was an internist and PhD in sociology, and said, you have to train us in mental health services research. So we wrote NIH grants and had 10 years of funding to train minorities to do mental health services research. And we had symposia and workshops and courses every summer for 10 years, where people would come and present and get trained. And then we had telementoring with some of the best people in the country who were doing services research at that time, helping to train these half a dozen or more people every single year who were a cohort. And that cohort would come for 2 or 3 years of training, and then other cohorts would come in. So we really had a very nice community that we grew of Native and Hispanic, primarily minority faculty who were psychiatrists, nurses, anthropologists, people in every field learning how to do this kind of research.
Wow, that's very impressive.
That was a lot of fun.
Yeah.
The other things that I've done that have been fun is about 20 years ago or 25 years ago, I became part of the original group of editors for Journal Watch Psychiatry. And that keeps me on my toes because every month I have to write about 4 to 6 pieces that go into Journal Watch. So about half a dozen of us scan roughly 40 journals, picking out what we think are the highlights, and that keeps us very informed. We peer review each other's articles, so we're all reading what everybody else writes as these little pieces are being developed, and that's been a very excellent activity. Coincident with that, Up to Date started getting interested in psychiatry and put together an Up to Date editors group, which for one reason or another has a large overlap with the Journal Watch group. So I've been the Up to Date section editor for eating disorders since the inception of that program as well. And I have about 20 chapters that I keep revising and recruiting for and learning about.
What do you think are the most salient issues facing, or in that area within psychiatry right now?
For psychiatry in general?
No, for eating disorders.
I think for eating disorders, it's always a matter of access to service. Mm-hmm. I mean, we see tons of people who are needy with limited insurance, and the fact is that eating disorders are very expensive to take care of over time, particularly severe anorexia nervosa. So seeing that patients have access to services is very important. The other thing that's necessary is to have enough individuals everywhere in the country who are trained to take care of people with eating disorders. There are specialists in psychiatry and psychology and nursing and social work, particularly in several of the large cities, but many of the suburbs and rural areas don't have enough people who are skilled in taking care of these patients, particularly the ones who are very ill.
And how did you get involved with Journal Watch? Were you invited, or how did that occur?
Yes. One of my very good friends years ago was a fellow named Gary Tucker, who was originally at Yale, and Gary then became chair of psychiatry at the University of Washington. And Gary was a journal editor, and he was one of the people who was a director for the American Board of Psychiatry and Neurology. And I worked with him at the boards, and I worked with him on some of the other journals. And when he was asked to become the editor for Journal Watch, he asked if I would be one of the people to play with him. We have a terrific group of people from around the country who do that. Tragically, he became ill at a young age and died. And then one of my own former residents, Peter Royburn, who went on faculty at the University of Washington and was chief of psychiatry at Harborview, was in place. And I said, Peter, you have to pick it up from Gary. So Peter has become the editor-in-chief, but the rest of us have basically stayed and played with that thing for all of these years.
It's wonderful.
Yeah.
You've spoken about and written about the importance of networking and making connections and collaboration, and I'm wondering if you have any thoughts on what you would recommend for residents who are perhaps more hesitant to network, what that means, how they might make some of those connections.
Right. I think networks are possible at every level. So that means local, regional, and national. I think what you would want to do is know what you're interested in and then find basically people to play with. So you need people to speak to and with whom to discuss whatever it is you're interested in. If it's psychotherapy, great. If it's psychopharmacology, if it's a certain disease, if it's a certain technique, and if it's political or economic, there are always people that you're going to want to deal with. So my suggestion is to find out what's available both through the APA regionally and nationally. There are always invitations for residents to participate, for fellows to participate, and also through subspecialty organizations, so that there are associations who are focused on mood disorders, schizophrenia, psychotherapy, psychoanalysis, psychopharmacology, you name it, and there are organizations, and all of them have invitations for young people to kind of hook up and get involved one way or another.
Wonderful. Another question that I have is, you've mentored a lot of people over the years, many, many people. What do you think are the qualities that make a really good mentor?
I think there are several. One is not being able to not take credit for what your mentees do, spotting talent, knowing what they want, helping them to formulate what they want, kicking them in the butt and getting out of their way. And then being there to provide the resources or the connections that really good people will be able to take advantage of, to show them where they may be wasting time, to show them where they're missing an opportunity. So that's really what a mentor will do, to guide people to write, to tell them when they're ready to do it, to help people who may feel a little bit inhibited to get over their problem and to move to the next level, to take people who think they're too good and to slow them down a little bit so that they don't rush over a cliff, into oblivion. And so it's a matter of guiding people to inspire them, but also to help them to develop their innate interests and talents to the best of their abilities.
What about in terms of writing? Many residents talk about wanting to write a paper or to get involved, but not all have that much experience. What would you recommend there?
The first thing is to sit down with somebody who cares about that, a writing mentor. I think it's always a great idea to start out with a case report just to get your feet wet and to show that you can do this. Because for many people, the idea of publishing in professional journals is I've used the analogies like losing your virginity. And you have to say, oh my God, some people are just intimidated by the idea, but it's not that big a deal. And finding somebody to do this with is always great. Most departments have junior faculty and senior faculty who have more to write than they have time for, who are always looking for a junior person to tag along, and they're happy to make you part of the publishing team. So you can come on as a collaborator. I think it's always a great idea to find something unique, like a very interesting case. And if you're doing active clinical work, you're going to find interesting cases every single week. And they'll have a new twist, they'll have a new something to write about. And to get that out, just for the practice of it. And a new case report with 20 references shouldn't take you more than a week or two to put together. So the idea that these are construction projects rather than Nobel Prize winning poetry opportunities is something you have to keep in mind, to be real about it. But I think working with a writing mentor can help everybody who has an inclination to do some publishing to do it.
In terms of other things that you've focused on in your activities, you've talked about choosing ones that have a potential multiplier effect. Can you talk a little bit about what that means and why that's been important to you?
Yeah. Well, I think a multiplier effect means that what you're working on is likely to be picked up and will perhaps impact a larger group. So training people who do research has a multiplier effect because each of them is then likely to go out and do some very good work. Teaching people how to do something has a multiplier effect if they're going to go out and impact a lot of different patients. Putting together a significant practice guideline or review article will have multiplier effects because those are articles with high impact. I'm on ResearchGate right now and receive weekly reports about how many people have read what you've written. And they'll tell you how many people have read this paper, that paper, and the other paper, how many times you're being cited. And it's clear that certain articles will never be read by anybody, and other articles have a lot of interest. So I think in picking an area, you want to pick something where you believe that you have something unique to say or that will be stimulating or challenging to others, rather than being the 10th person to write about a certain topic where it's a Me Too article.
But at the same time, in the beginning stages, just going for it and producing and seeing how that turns out.
I think there are exercises. They're like practice exercises. If you were at an art institute, you have to learn to copy somebody else's work before you can really step on your own. Develop the steps for it. Composers do that all the time. They'll start by composing in the style of other people before they develop their own voice. So having a couple of those things going at the beginning of your career is not a bad idea, but never expect that they're going to be picked up and win awards. You want to have a unique voice and pick a unique topic or something new in the field that you know is going to be helpful and will be disseminated and ultimately will have some impact.
Okay. Excuse me. So you wrote in an article, I think it was the International Review of Psychiatry back in 2013, and I liked a lot of quotes that you had in that, but one of them was about learning and how to best teach. And the quote was, programs, meaning educational programs or residency programs that compel square peg learners to meet round hole requirements, forcing them to do things that they're not cut out to do, or wasting everybody's time. Mm-hmm. Can you give me an example of something like that? And
I think the curriculum that the RRCs oblige residency programs to undertake can be done in a very mindful way or in a mindless way. And I've seen a lot of mindlessness. Mindlessness occurs when you have a teacher who's not really interested in teaching assigned to do a seminar that nobody wants to attend. and the vibes in the room are soporific, and it's really a waste of time. So that's one way to waste time. Another way to waste time is to give people information at a time that they have no need to know it. So it's mistimed learning. So one of the very good notions about adult learning is to learn things just in time, when you need to learn things. So if you're seeing a patient, that's the time to read about something and to get supervision about it. This wonderful fellow, Louis Jolyon West, who was the chair at UCLA who recruited me, he did ritual in education systems, and he said the only thing you really need to know as a psychiatric resident to really learn are your patients, really good supervisors available to you who know that stuff, and a library. Of course, he meant an actual library. Nobody uses a library now. Everybody uses PubMed or you're online. And I think there's a lot of wisdom in that. So I think that educators should be always looking and asking residents, is this worth your time? Because residents are very sophisticated utilizers of time. And if we're wasting 5 or 10 or 20 hours a week in assignments that don't make sense, that's a tragedy. Though that's time that people could be using probably more profitably for their learning and for their patients' well-being.
If residents ever feel like their time is being wasted, how would you suggest that they go about bringing up that concern without appearing inappropriate or arrogant? Yes.
Okay. I think several suggestions. One is that it's best to do it as a group, because one person is a pain in the butt. 3 people are a political party. So you kind of get together as a group and figure out what you're going to do. The second thing is to realize that you are supposed to learn things, and you have to meet learning objectives. And I would have a discussion either with the course leader or with the program director about, here is a better way for us to really be learning these things. And you test us. You give us exams, and you see whether in fact we're mastering what we need to do. Are we mastering the skills and the knowledge that presumably this course is supposed to be imparting to us? Maybe we can do it even much better. One of the shifts in education over the last 20 or 30 years is going to problem-based education and to flipped classrooms. And what that means is the responsibility for the learning falls to the learner. In the old days, you'd come in and somebody would lecture, and the students, if they were awake, might or might not remember what they heard in a lecture. A flipped classroom means you kind of figure out what the problems are that you're supposed to learn about, and then it's up to the students to go and read and then come present what they've learned. So they're already demonstrating that the concepts have gone someplace between their hippocampus and and vocal motor lobes, perhaps going through their frontal cortex. You don't know. And the more of that occurs, presumably, the more assimilated that information will be in the learners. So the more responsibility and active learning that occurs in a teaching environment, it seems to me, the more the learning actually occurs.
What advice in general would you give to residents and fellows today? Just a few highlights.
Wow. Okay, the first thing is be flexible. Be prepared that what you think will matter in practice today may not be as important 5 or 10 years from now. Be prepared to learn things in all of the biological, psychological, and social and political and economic dimensions of medicine, because you're going to be having shifting sands in every one of these areas. I mean, if you want to be a sophisticated clinician, you're going to really have to know biology and psychology. If you want to be a sophisticated practitioner, you're going to have to know social medicine and economic medicine. Don't be surprised if you're called upon to do administration at some point, to be a teacher at some point, to be a supervisor. It seems to me that There will be a role for individual practitioners, not in groups, but as we can see over the last 20 or 30 years, that role has been slimmer and slimmer. To think that you'll always make your salary simply as an independent practitioner depending on cash collection is making a lot of assumptions about how society is going to continue, that there'll be enough people with cash, that there'll be enough people with cash who want what you have to deliver, as opposed to paying somebody else to do something that might as effectively get them beyond whatever problem it is that they're wrestling with. So again, you have to be flexible, and that means lifelong learning. Lifelong learning means as an individual learner and learning in groups. So you want to find peer groups, you want to find other continuing education opportunities all the time. I think the same applies to continuing education as applies to residency training, which is don't waste your time with Mickey Mouse things. There are too many Mickey Mouse requirements in maintenance of certification these days and things of that sort. Pushing back on the accreditation groups to make sure that accreditation requires meaningful learning is a very important responsibility for each and every current and future practitioner.
I think somewhat tied into this is the fact that you're an independent thinker, and you've described yourself as, I believe, a psychotherapy contrarian in the past. Can you talk a little bit about that?
Yeah. I don't like labels for schools or tribes. So if anybody says, I am a this-ist or I am a that-ist, I find I have an instinctive negative reaction to that. I don't sign up for any political parties. I like to think on my own, and I think in psychiatry that's been very useful. It means that I don't get wedded to the idea that diagnoses are wholly entities. They're not. They're constructions that try to describe human phenomena. I don't believe that any schools of psychotherapy have precedence over any others. They all look pretty much the same under the skin, and you have to be careful in deconstructing what the help elements are. I don't think medications are necessarily what their labels call them to be, so that antipsychotics or antidepressants are not just antipsychotics or antidepressants. They work on certain nervous systems in certain ways that we're still figuring out. So getting away from categories and labels and being able to think beyond them, I think, is a very important function for an independent thinker.
Do you think that that kind of attitude can help residents and fellows and actually anyone develop resilience and prevent burnout?
Sure, because it means that everything is fresh and new. You're thinking about old wine always from a deconstructed perspective, and that means what new configurations are there? How do these things come together in novel ways that haven't been described by these categories? That's creative thinking, and that's always stimulating. I think that will keep your dopamine surges going.
So you're also a voracious reader and are always disseminating recommendations for residents, fellows, everyone to read certain articles or certain books. If you could name 5 books that you think are essential or very intriguing for residents and etc., what would you say?
Okay, I'd say beyond the standard textbooks that you want to keep up with, things that that have been important in my career are Jerome Frank's books on persuasion and healing. 3 editions, the third one, the most recent, was written in the 1990s with his daughter Julia. It's still excellent for stripping away what psychotherapy is really about. An old book called Listening with the Third Ear by Theodore Reich, who is a lay analyst who worked with Freud at some point, if I'm remembering correctly. But anyway, it has to do with listening between the lines and being a good clinician by being careful and subtle in understanding human communication. And several other books that you'll find listed under this in the post that goes along with this talk.
Okay. So just a few more questions for you. I guess, what have you liked the best and the least about being in psychiatry?
I think what I've liked the best is the fact that every single person is different. And so as a clinician, I have never been bored. I couldn't imagine seeing 50 cases of the same influenza every single day, or hot ear, or something like that. I mean, it's important to take care of people, but from a subjective perspective, the variety of human experience has been absolutely stimulating and terrific. I think what is difficult is seeing how people suffer when they lack access to care. Even in our own clinic, which tries to do really good work, insurance plays too much of a role in knowing how long people can come, or if they can no longer come to the clinic, or what services they can access. And I think that's a very, very frustrating thing in all of medicine, but I've seen it particularly in psychiatry.
And if you had your career or life to do over again, are there any things that you would do differently?
No. Isn't that I mean, when I've been blessed, I've had a terrific career, I've been smart enough to know where my strengths and limitations are, and to avoid taking on roles where I just don't have the right stuff. Mm. And I think that's a really important thing, to know what your own aptitudes are, to be tuned into that, and to not be seduced or take the narcissistic bait of taking a job just for its title if it doesn't call out your talents, and if it also doesn't provide what it is you're looking for in life.
Absolutely. Well, thank you so much for speaking with me. I really appreciate it. Dr. Yager is one of our most beloved professors, and so it was an honor to get to speak with you today.
Terrific. Thanks so much.
Thank you.